Thank you very much. And good morning, everybody. I'm really, really pleased to be here. As an activist, South Africa is a country that inspires me. As I walk around and look at the pictures of Nelson Mandela and Desmond Tutu on buildings and on your banknotes, I can't help but think about what we as communities, as societies can do when we come together to make the wrong right. South Africa is a testament to that. I work at the Global Fund, which was co-founded by another great African, Kofi Annan, and he said that drugs have destroyed many lives, but wrong government policies have destroyed many more. It is obvious that after 40 years of war on drugs, it has not worked, and therefore we should be decriminalizing drugs, and we should remember this as we move on. In preparation, it's not moving forward. In preparation for this speech last night, lying in bed, I was thinking, why is this such an important topic for me personally, apart from the global? And I realized that I belong to at least 5 of these different categories. Everywhere you go, one of us belong to one of a section of society that is discriminated or criminalized somewhere. Since 9/11, I can't walk through an airport security without being stopped and searched because poster boy for terrorism, it looks like. And I certainly, when it comes to people who use drugs, I certainly don't believe that we should criminalize people who use put something in their body and don't hurt other people, just like I don't think that we should be punishing women for the choices that they make about their own bodies. So coming on to the world, and our theme for today is from policy to practice, and then before we look at the policies, let's look at some of the realities of the world. Steve asked, why are we giving, if something is so harmful, why are we letting the organized criminals to regulate this? Why are we giving it away to organized crimes to handle something that is so dangerous, that you think is so dangerous and risky for our societies? UNODC World Drug Report, every year states that every year more and more people report using drugs at least once. The last 2017 report says at least 250 million people, 250 million people have used drugs at least once. Around about 17 million people inject. Every year there is a new synthetic drug, so there's a new type of drug that comes on. Every year the drug routes change, and therefore exposing new communities to drug use and injecting drug use. And millions and millions and millions of people, young people, are going to prisons and by being incarcerated and put in cages. My screen just went off. Okay. I have worked in about 28 countries in here so far, and I wanted to give you the realities of 3 people that I've met around. And I want to tell you their stories before we talk about decriminalization. And these stories are not very sweet, and they're very hard to swallow. So I brought you Swiss chocolates to make this a little bit better. Monique, would you open this and give it to everybody, share it around? That's from Geneva, where I live at the moment. So. The first story, ladies and gentlemen, starts in Dushanbe, Tajikistan. In Tajikistan, about 60% of the male population, adult male population, working population, has migrated to Russia because there are not a lot of jobs in there. So leaving behind their young wives and sometimes 2 kids. And they spend a long time in Russia. Some of them don't come back. Some of them get married in Russia. And so the wives and the kids have to fend for themselves. So in Tajikistan, is very arid, so they take potatoes and root vegetables and go to the market to sell to feed their kids. Tajikistan is a river crossing away from Afghanistan. Along comes, the producers, the dealers from Afghanistan, look at these young women and go, you are so young, why are you, in the market? I can change your life. If only you would carry this small little parcel on this train to this place. And the women, of course, in desperation, in the situation that they're in, they do carry. And the police gets wind of this, both Russian and Tajik police, and they make a policy to catch all of these women. And so in Tajikistan, there are prisons where there are around 600 women who are there for years and years because they were carrying something so that they can get some money to feed their kids. So they spent 12 years in prison, like Michelle pointed out yesterday, 12 years in prison, and their kids back home are growing up on the street. So they end up on the street. So the next story, we go to Dhaka in Bangladesh. In Dhaka in Bangladesh, I met with a 12-year-old boy who was living on the streets and injecting. 12 years old. So I started asking this boy, why are you injecting? How did you even start using drugs at such a young age? He tells me the story. The street kids are often invited by rich people coming by cars so that they can take these kids to their homes to clean their houses. Cheap labor. So these kids get into the car and go to these rich people's houses to clean these houses. And of course, kids are clumsy. Kids don't, they're not very good with things. They sometimes break things while they're cleaning the house. And when they break things, the rich people beat these kids up so bad. So the dealers and other kids tell these small kids, if you are going to go and clean someone's house, if someone comes to take you, before you go, take this. It's painkillers, opioids, heroin. Take this so that when they beat you, you don't feel the pain. And that's how they started using the drugs, until by the time he was 12, he was already injecting the drug. So this is the life of the street kids, using drugs on the street. And then our policies, as soon as we find a little bit of drugs on these kids, we take them to a detention center or incarceration center. And here in Indonesia, we meet Frankie, friend of mine. Even before he was 12, he was sent to prison for having small amount of drugs on him because he'd been growing on the street, he's been using drugs. So just a small amount of drugs has been put in prison. In prison, he gets caught up with the gangs. His gang in the prison had 30 people. Another gang had another 30 people. They are constant rivals. One day in the prison, they managed to get the drugs of the other gang. They had a fight. They managed to get the drugs of the other people. So they were going to use the drugs in the prison. It was heroin. 30 people standing in a line. One guy at the front is cooking the drugs, and he's starting to inject all of the members. It was a makeshift needle. And Frankie is number 27 in the hierarchy of this one. So he's number 27 on this one. And the first guy is cooking and injecting every single person. And all Frankie could think about was, is there going to be enough when I get there? He was number 27, one needle. That's how he got infected with HIV and hepatitis C. Because of the policies, because he was put in prison. And so this, ladies and gentlemen, is the reality around the world. If the UN Convention's goal is to protect the health and well-being of the people, if the goal of our drug policy is to protect the health and well-being of people, if the goal of our councils, our cities, is to protect the health and well-being of people, are we actually doing that by the policies that we currently have? The experiences of Dushanbe, Bangladesh, and Frankie in the prison suggest we're not doing that. So it's time to move on. It's time to ditch the policies that are not working, that are not protecting our brothers and sisters, and move towards prohibition and move towards decriminalization. We need to do that. Harm reduction supports the health and well-being of people. We know that. But it's a symptomatic treatment. Sometimes, without the change in drug policy, without the change in actual policy, it remains fragile and threatened whenever there is a change in government or change in the policymakers. We invest hundreds and hundreds of thousands of dollars in supporting study visits for law enforcement leaders or policymakers, and then when the government changes, they go away. Somebody new comes on, they start a new policy. However, sometimes change of government also presents an opportunity, which is what we saw in Malaysia, which what happened in Malaysia, and I'm going to talk through the experiences of Malaysia in just a little while. So in 2005, the Malaysian Prime Minister decided that we should do harm reduction. So in 2005 and 2006, we developed a national harm reduction pilot, and we had drug needle syringe programs and methadone across the country. Oops. Okay, and this is what happened. Total number of people registered. Total number of people who went on NSP was 85,000, and people on OST was 75,000. And you can see that between 2005 to 2015-16, the number of infection, HIV cases, has reduced dramatically. A study done by the University of Malaya suggests that we have prevented, in the first 7 years, we have prevented about 40% of the new HIV infections with harm reduction, with these programs. So, successful harm reduction programs in Malaysia. However, new drugs come on board, like crystal methamphetamines, and it starts penetrating into new communities, such as men who have sex with men. And a lot more men who have sex with men start injecting. They're not on the streets. They're afraid to come out. New epidemics begin. Prison population in Malaysia is still high. Anywhere between 60 to 70% of people who are in prisons at the moment are there for small drug-related crimes. And criminalization has not contributed to better quality of life for a lot of young people in our country. So what happened was, earlier this year, there was a group of academicians and new government legislators who come together and wanted to find a new way to deal with drugs. And so this has been brewing for a while, because there have been a lot of wonderful researchers, just like you have in South Africa at the moment. They got together and they said, okay, we really need to approach the new government to introduce a new drug policy. And so when they asked me to support, I was very excited. And so, really needed to do something about Malaysia. So I decided that I needed to study the Portuguese model really well to recommend decriminalization, as they were asking for, before we went and met with the Minister of Health in Malaysia to present this new model. So, so I went to Portugal, met with the implementers in Portugal, and so these are the things that I found out. Number one, in 2001, Portugal decriminalized all drugs for personal use and possession. So all, heroin, cocaine, all of that, they decriminalized. It's still illegal, but it is decriminalized for personal use and possession. So basically what they did was they moved it for anyone who's caught within this limited amount. They moved from criminal offense to administrative offense. There are a lot of arguments whether or not it should at all be offense, but Portugal decided that, moving it from criminal to administrative one would make a huge difference in people's lives, and it has. They developed a threshold level, so just to identify so that everybody knows what's the amount for personal use and what's the amount, if it's more than personal use, it'll be considered dealing. So they calculated that based on 10 days use for a person who is using that particular drug. They clearly defined a new policy and a new system, and they developed a committee called the Distillation Committee. So everyone who's caught with a small amount of drugs is not sent to the court. The police will direct them to a board of 3 people, where they will go and meet these board members and discuss their drug use. And that was called a Distillation Commission. And not last but not least, one of the biggest thing was to increase the access to drug treatment. So they had drug treatment in all of their provinces, particularly methadone maintenance program that was low threshold and easily accessible. So their results have been really good. They've been studied quite a lot over the last 10, 15 years. They have been researched, the monitoring and evaluation through the European Center for Monitoring has been quite rigorous, and we can see that they have produced good results, including reducing the number of people going into prisons. So a lot of young people This is Manuel Cardozo, part of SICAT, which provided the leadership for the creation of the new drug policy. So one agency was put in charge by the Prime Minister at that time. They created a board, they created a group of researchers and said, please go out and find out what we need to do to change our drug policy, to make this better. So the group of researchers went out under the leadership of SICAT and came back and proposed decriminalization. Then they created a new system. This is Nuno. Nuno is one board member of the Distillation Commission. He's standing with all of the files of people who have been there. In a year, they see about 3,000 people who the police refer them to. Out of these 3,000 people, only 12% of the people who are referred require any kind of sanction or referral to treatment. The rest, based on evidence as well, we know don't need any kind of sanction, don't need treatment, because we know people who use drugs are not all of, anyone who uses drug becomes dependent on drug. We know that only 10% or so will require support and treatment. So Nuno tells me that about 85% of the time they speak to them. There's a slap on the wrist because that's what the law requires, but they go on with their lives. They're not put in prisons or cages like Frankie was. This is a methadone program. They make their methadone program as accessible as possible throughout the country. That's a take-home dosage for methadone for patients. That is a mobile bus that allows for methadone to be brought to the streets where people can come and take methadone. And this was really interesting. This methadone program was incredibly interesting. I was standing there looking at this methadone program, and there came a taxi driver with his passenger behind. He comes to the methadone bus, parks his taxi, takes the methadone, gets back into, drinks the methadone, gets back into the taxi and rides, and continues with his life. The second group was this construction worker in a big truck. The truck pulls up next to this methadone truck, pulls up. The driver is waiting. This guy comes down with torn jeans and looking really rugged, takes his methadone, says hello to everybody, jumps back on the truck, and off they go to work again. It's made into not a big deal. It's not a big deal. I have a dependence, I have to do something. I have to go every day and take this medication. It's not a big deal. Methadone doesn't have to be a big deal. It doesn't have to be tightly controlled. It doesn't have to be expensive. It doesn't have to be difficult to access. We don't have to worry about leakages. We don't have to worry about people selling it to other people. We just have to make it easy and accessible to everyone. That was right. So based on that, I developed a 10-point roadmap for decriminalization for Malaysia. because I knew that when we're sitting in front of the minister and the politicians, I needed to be very concrete around how we move this forward. So this was the recommendation that we made to the Minister of Health. Number one, we need to set up a multi-sectoral commission for drug policy reform. I keep pressing something in here that's not very helpful to my cause, so it's gone. So it's number one, set up a multi-sectoral commission on drug policy reform that would have the Ministry of Health, the drug control agencies, the religious department, the agency that is responsible for treatment of people who use drugs in the country. That is important to get consensus in the country. Number two was to conduct a study, a feasibility study on decriminalization in the country. Just like you, I've been hearing the last 2 days that, even in Durban or in Cape Town, you're always asked, how would something that works somewhere else work in our country, because we are different. We've heard this argument many, many years now in HIV as well. How do you know that something works in overseas will work here? So, we know that it works, but, just to make sure, we'd conduct a feasibility study. So we recommend a local research on how to do this in Malaysia. Number three is to expand methadone. So methadone is already widely available in Malaysia. The next step is to ensure that private doctors are also able to access it, and mobile units if it's needed. Number four, development of the threshold for personal use. So how do we define what is personal use and what is large quantity for dealing? And this needs to be done with the network of people who use drugs. As, if politicians and police and doctors make a decision on what is everyday use, what is personal use, that's not going to be right. It needs to be the people who are using the drugs who need to make that decision. So we need to consult people who use drugs. Number five is a development of a diversion away from the courts, away from the criminal justice system, whether it's a Distillation Committee or another form of a board. Then we need to figure out a different mechanism for a committee. Number six, ensuring that there is changes in the law enforcement policies. So police in Malaysia have a quota system. So every month, the police officers need to arrest a certain number of people who use drugs, a certain number of criminals. And because people who use drugs are criminals, they are the easiest people to arrest and fulfill this quota that they have. So we need to get rid of that. We need to make sure that the police practices change. Number seven is to capacitate all other relevant authorities, religious bodies, drug treatment bodies, rehabilitation bodies, education department, prisons, criminal justice. Number eight, if we need to do pilot projects, we need to start looking at where is the best place to do it. If it's one particular city, one particular state, then we can recommend that. In Malaysia, we recommended 3 sites for pilot studies, 3 sites where drug use was the highest according to our research. Number 9 was preparing arguments and media campaigns around to address the challenges and the criticisms that we are bound to get. Definitely, the decriminalization and regulation of drugs, we can talk about it because we've been working on it so much, but when we go out, we need to actually change the cultural mindset, the mindset of 50, 60 years of the war on drugs. People have been told drugs are bad for you. You don't know what to do about drugs, just call the police, because putting people in prison is the best way to deal with drugs. That's been hammered on people's heads for 40, 50 years. You want to change that? That's a cultural shift that needs to change. And we need to figure out how we change this mindset, this belief system that was created by the war on drugs, by prohibition. And we need to figure out media strategies, campaigns, to address these challenges. And then, last but not least, have a really good monitoring and evaluation mechanism so that we are picking up all the challenges, all the unseen consequences of changing this drug policy so that we can address them as quickly as we can. Okay, so this was the meeting with the minister, surrounded by incredible researchers and doctors. And so we've been very glad to be involved in that process in Malaysia, and support the developments. Until today, it's going really well. It's going actively. The researchers and the doctors are working really actively. They've got subcommittees working on the different areas of the 10 roadmaps that I talked to you about. If you would like more information, I'm very happy to sit with you or put you in touch with people who are leading that in Malaysia as well. Now, a little bit about Global Fund. We have our previous executive director here as well. It's a great organization, largest donor on HIV, TB, and malaria. South Africa will always remain eligible. There was questions to me earlier this week around whether or not South Africa will become upper middle income country and therefore will not be eligible. That's not the case. We're focused on key populations and evidence-based programs. We follow the technical guidelines provided by our technical partners, including UNODC. We have a good technical brief on harm reduction, which says that we support the interventions that our technical partners recommend, and we also support the efforts to remove the legal barriers to HIV, including conducting advocacy. So you can put in advocacy efforts into the proposals that you submit to the Global Fund. And we also work a lot on interventions to prevent human rights violations, stigma, and discrimination. So Monique asked me to also say that, mass is small. Last night we were talking about, and that the fact that there is this funding, there is this support from Global Fund to support advocacy work, and if we can actually do these experiments, we can actually move the agenda forward around removing legal barriers. We are here to support that sort of work, which will be hand in hand with prevention of HIV and hepatitis C. So we must end prohibition, clearly. We need to promote decriminalization and regulation along with harm reduction. And what are we working for if it is not for the health and well-being of our brothers and sisters, right? There was a question to Steve earlier this morning around, how do you do regulation in South Africa, when it's impossible to do regulation on everything else? So, and I think that reminded me of Nelson Mandela's quote, which is, "It always seems impossible until it is done," and you have done it. And we have done it, If I remember my start in harm reduction, people didn't even believe that we should be handing out needles or handing out methadone. Today, it's like, it's accepted as if, it was just an easy idea. Decriminalization and regulation might seem really impossible today, but, that's why we are here. If it will seem impossible now, but when it's done, it'll be good for all of us. Thank you very much.